so she's obviously introduced for me. I'm looking at, my current study is looking at the barriers and facilitators to intensive, comprehensive services, and also a relatively new model of service delivery, which is an ICAP, an intensive comprehensive aphasia program. So obviously, when we're looking at clinical guidelines, what is a comprehensive service? So we're thinking it's obviously client-centred, variety of therapy approaches, involves significant others, and targets a range of communication functions as per the ICF. However, when we're looking at intensive aphasia services, identifying that optimal level of intensity has, however, proven a little bit more difficult. This is obviously because when we're looking at the heterogeneous nature of aphasia, there's obviously lots of patient-related factors, and also there's difficulties defining the intensity as well in all of this research. So there is, however, growing strength of evidence within a recent Cochrane review of the more is better with intensity. So, and that was actually defined between 4 to 15 hours a week as high intensity. When we look at an ICAP, we have the intensive elements and also the comprehensive elements. It is, however, completed as a cohort, and there's a definable end and start date to these programs. So it's almost a bit like a boot camp for aphasia services. There has been gains in communication outcomes for ICAPs in current literature, and as a relatively new model of service delivery, there's a few established within a couple of countries. So within the survey of practice in 2012, there were 12 ICAPs identified, and these were across the US, Canada, Australia, and also the UK. Now, they were predominantly funded by participants, and they were at this point, 7 of them established within the past 3 years. Now, unfortunately, difficulties with implementation have contributed to an evidence practice gap, with difficulties achieving the optimal or achieving a high level of intensity, insufficient training of both individuals with aphasia and also their family members, difficulties providing this holistic service, as I mentioned, the comprehensiveness, and insufficient availability and access to these aphasia services. Factors influencing implementation are quite complex, and we can look at them in a various number of ways. We can see there are clinician-related factors, environmental factors, and also client-related factors that can be both barriers and facilitators. If we're looking specifically at ICAP, some of the positives or facilitators to implementation have been the relationships that have been built, the being able to learn an evidence-based practice and seeing the great outcomes for the participants. Some of the barriers or things that were a bit challenging have been the time required to prepare for this therapy, and also the expectations of some of these individuals with aphasia and their outcomes. So if we're looking at the aim of the current research, or my study at the moment, we're looking at barriers and facilitators, and we've separated them into the intensive, comprehensive, and ICAPs as well. Now, we have included this across 6 different countries, as I mentioned, because there are a few that have been established internationally. And also, if we're looking at internet resources and web-based programs, this now actually facilitates us to share information on that larger scale. So we're getting a greater understanding of these programs, but also we're able to share on a wider scale a lot of these materials. And this also means that we could potentially use this with our intervention to actually help support clinicians to implement, whether it's intensive, comprehensive services or ICAPs. So we had focus groups conducted in these 6 countries. They were picked because similar standards in clinical practice, as they have a mutual recognition agreement with Speech Pathology Australia, their professional bodies, and also they are all English-speaking countries as well. So when developing a tool, or predominantly English-speaking, this is obviously going to make this a bit easier. So participants, we had 34 speech pathologists participate. They were purposely selected across all of these areas, so we had a nice variation. And they were experienced clinicians in the field of aphasia. We had 22 participants, interestingly enough, say that they were consistently providing the recommended levels of a comprehensive service, and only 9, I suppose, that were providing a level of intensity that was recommended. They were all, however, familiar with the concept of the ICAP. So when we're looking at the analysis of these transcripts, so the thematic analysis actually used predetermined codes as per the theoretical domains framework. So the 14 domains actually are potential influences to implementation. So even though we used these 14, if there was information that didn't quite fit, we were actually able to add these items in. We didn't just disregard them. There were things that came out quite strong, like patient-related factors and also organisational structure. However, when we recoded these items, they were able to be fit into other areas and predominantly within the environmental context and resources. The results of this study, so even though we did try and separate each of the 3 services with our focus group questions, we did find that speech pathologists would often talk about multiple services together, or there was repetition of barriers and facilitators across each of these services. So we were able to actually identify 5 key domains that influenced all aphasia service types. And within these 5 key domains, there were overarching themes. So we had collaboration, advocacy, culture, and innovation, which we'll go into in a bit more detail. So when we're looking at collaboration, we're looking at joint initiatives and partnerships that speech pathologists actually establish. So there's been a movement in collaborative working, so acute speech therapists and community speech therapists working together across this stroke continuum of care. And this has had positive outcomes for the implementation of these new models or changes in service. Networking, so again looking at collaboration, so we're looking at the facilitation of clinical resources and also greater access to maybe clinicians that have greater experience working with individuals with aphasia. Lastly here, positive experiences and outcomes with joint initiatives. This then reinforced and made people feel that they were more able to implement something new when they'd had a good experience in the past. Now, the theme of advocacy refers to promotion of not only aphasia services, yet evidence-based practice also. So speech pathologists actually felt quite empowered when they felt they had the skills and knowledge to advocate for aphasia services. And they felt it was their responsibility not only to educate about the recommended practices, yet also to promote this self-advocacy of individuals with aphasia and also their support networks. And organisations' receptiveness, however, also held the potential to negatively impact the success of implementation, and therefore also continuing advocacy for aphasia services as well. Now, when we're looking at culture, which we looked at as the underlying values of either an organisation or an individual, there was an impairment focus or medical model that was often seen in a lot of these speech pathology departments. And this often therefore impacted, there was almost a devaluing of communication therapy and also a few difficulties being able to move from this rudimentary impairment-based therapy model. There was, in the UK especially, aphasia was seen as more of a short-term condition, so therefore therapy was time limited. rather than if it was looked at as a chronic condition, then they'd have more long-term services. So they were advocating quite strongly there for further education and research as well. And lastly here, fostering research. An organisation fostering research and evidence-based practice obviously supported implementation as well in some of those organisations. Now, the theme of innovation, so we're looking at problem solving a lot of these challenges that came up. So there were things like creative resourcing, so if there was geographical barriers, then using Skype, as was mentioned before also. The level of flexibility of a speech pathologist's role as a facilitator in being able to implement change. Problem solving was highlighted when with patient-related challenges. So obviously we come across a lot of things like motivation, a patient's readiness for therapy, and being able to problem solve how do we individualise this therapy to engage them that bit more. And also practical knowledge and skills were required to actually translate this evidence into everyday clinical practice.